All right, so thanks for coming. As you know, my name is Anthony Rossi, and I'm a second-year DAT student at the University of Idaho. And today I'm just giving a presentation regarding the residency portion of our program. So this is just kind of an overview of what I've done through our residency portion of the program and how it has impacted me as a professional and personally, and also hopefully how it's impacted the sites that I've worked at. So the objectives of this presentation are just to give you a brief background of my education and career up to this point, talk about why I chose to pursue my DAT, discuss how I've developed as an athletic trainer, both with my clinical practice and personally, talk about what all of the changes and everything mean to me and to my clinical practice, discuss a little bit about what I think is next in my education and career, and then just have some time for questions if anybody has any. So just a brief background, I did my undergrad in exercise science at Adrian College, and then it was a 4+1 program there, so I stayed for a fifth year to get my master's degree in athletic training. And then after that was when I was able to sit for the BOC and start working that coming fall. So obviously once I finished my graduate program, I would consider myself to have entry-level knowledge of athletic training, and was fortunate enough to get my first position at Adrian College, which is a D3 institution. And just with the patient volume there and the variety of sports, I was fortunate just to gain a lot of experience very early on with a variety of patient populations. And so that, I think, was definitely a great spot for me to have my first job. Fortunately, obviously, going through the program, I was able to gain a lot of experience there through clinical rotations and had a lot of autonomy in my first couple of years working there. And really what I realized for those first couple of years of working is just exactly how little I knew and felt that I had just kind of scratched the surface of athletic training. And now fast forward to current day, obviously I'm here at Western Michigan University. So why did I choose to pursue my DAT? Really just, again, through those first 2 years of working, I just kind of realized that I needed to know more. I wanted to improve myself both as a clinician and a scholar, so I started to explore options to further my education. I decided to go the DAT route because I knew that I wanted to continue working clinically as an athletic trainer, so I didn't want to put my career on a hold and pursue like a PhD or be a full-time student in that respect. So I knew I wanted to do something clinically to further my education in a realm of specifically to athletic training. So I started exploring DAT options, and obviously there's a few throughout the country here, but I decided on U of I just based on their philosophy and their curriculum. I just felt that it was the best suited for me. It was a mixed model curriculum, so I went there for 2 summers and was actually on campus in the classroom, which for me, I was intrigued by that because I feel that I learn better when I'm actually in a classroom. And I had never taken online courses before, so I was a little concerned about how that was gonna go, especially with working full time. But so the first summer on campus was great just to kind of get my feet wet with my doctoral work and feel comfortable moving into the fall of working and pursuing courses online. And just their philosophy of their kind of 2 models of advancing clinical practice by expanding our clinical skills as well as working on our research and evaluation skills by evaluating the current evidence that we have and applying it in our clinical settings, and then also developing our own research and then sharing that with the profession. So I feel that I've developed in many ways as an athletic trainer over the past 2 years. In regards to my clinical practice, I feel there's a few areas. First and foremost is my evaluation and treatment philosophy. I feel has changed a lot. I feel now that I have more holistic evaluation approach where when I first started in athletic training, I would say that I definitely had more of a local perspective of my evaluations, kind of had blinders on. Patient comes in with pain in an area, I'm looking at that area and that's what I'm trying to figure out. Whereas now definitely expanding my evaluations to have more of a global approach, realizing that the body is obviously interconnected, and just because somebody has pain in an area doesn't mean that's the source of their pain. And then lastly, for my evaluation, which I feel is very important, is just encompassing the whole patient. I think that all of us working with intercollegiate athletics can appreciate how much a patient's mind can definitely affect their body. and just taking that into perspective during my evaluations and while working with patients, which is something that I definitely did not do very much early on in my career. So just realizing a simple question of asking a patient how they're doing that day, and understanding obviously there's so much more going on in a college student's life than just their sport. So that is something that I feel has definitely improved my patient care. In terms of injury classification, I'd say it's definitely shifted from viewing everything as musculoskeletal damage to more of viewing things as dysfunction. I think that this is meaningful because when we view things as a dysfunction, that opens up the realm of possibilities of ways that we can treat something. For example, if we're looking at an ankle sprain and we think this is ATFL injury, there's tearing of the ligaments, we're not going to be able to do much to speed up ligament healing, right? Like that's just something that's going to take time. The body heals in a specific way. We can obviously promote healing by putting the body in a positive environment. But if we view things more as a dysfunction when there isn't possibly, if we don't know for sure that there's muscle tearing, ligament tearing, things like that, then we can treat things in a variety of ways when we treat it as a dysfunction. For example, using Mulligan distal fibula mobilizations with movement on the ankle to help decrease a patient's dysfunction and decrease their pain and improve their overall function. It just doesn't box us in as much if we're classifying injuries in a different way. In terms of treatment paradigms, obviously as a profession, athletic training is very much moving toward manual therapy driven, which I think is great. It's something that I have a great interest in. And again, through U of I's program, we took a lot of manual therapy courses on campus during the summers. So that has been something that I've been very interested in and feel that I've been able to expand my knowledge and skills of manual therapies. And the unique thing about a lot of the manual therapies that we learned were a lot of them are pain-free interventions and interventions that work in a patient's direction of ease as opposed to in restrictions, which I think is meaningful because it can help improve patient compliance when obviously they're coming in and we're not creating pain for them, as well as improving their outcomes when we're working in directions of ease. The biggest thing that I think has changed is the implementation of outcome measures. For me, in my clinical practice, this is something that I was not introduced to during my undergrad or graduate programs very much. So I did not collect these early on in my career, but going through the U of I program, I've learned a lot about patient and disease-oriented outcome measures and how useful they can be during our evaluation of patients, during developing our treatment plans, progressing our patients through the treatment plan, and justifying our discharge and return to play criteria. So that's one of the biggest differences in my clinical practice. Lastly, in terms of clinical practice, I feel that as a profession as a whole, athletic trainers are trying to gain more respect in the healthcare profession. And I think a lot of that can come down to holding ourselves to a higher standard and changing our vernacular of how we treat ourselves and how we treat our patients and the environment that we work in, kind of taking away the trainer, the training room, and focusing on this is an athletic training clinic, this is a healthcare facility, and carrying ourselves in that way, I think can go a long way in gaining more respect from other professions. In terms of how I've changed personally, a big focus of our program is having mindfulness. To me, what that means is having an increased awareness of myself and my patients, meaning an increased awareness of my thoughts, feelings, and emotions so that I can be the best me that I can be to help my patients. Because if I'm not feeling well that day or something's bothering me, then that's going to project onto my patients and probably negatively affect my patient care. And then also having an increased awareness of my patients, again, going back to asking them how they're doing, kind of looking at other areas of their life and seeing how we can help them that way. Personal growth has been a big thing for us, obviously, just setting goals, making plans to achieve those goals and kind of going through that semester by semester through this program and just planning new goals as we move forward after we finish our program. And then lastly, just the work-life balance, which I think is a huge importance for athletic trainers, especially young ones with the burnout rate of athletic training, just realizing how to kind of balance your lifestyle in order to still have that desire to continue working clinically. Obviously, we work long hours, especially in the collegiate setting, and finding time for yourself, finding time for family and friends in order to keep that balance. So what does this all mean? Ultimately, I think it comes down to two main points for me. It's just improving patient care and increasing my job satisfaction. In terms of patient care, again, it's coming down to having measures of success for both my patients and for myself through these outcome measures in order to constantly reflect and analyze my patient care and allow the patients to see the improvements that they're making, or maybe they're not making improvements, and that's when I know that I need to make a change. Again, this is justifying our return to play decisions. It's helping us with our evaluations and being more all-encompassing with our patients. And then obviously, increased job satisfaction comes along with all of us probably joined this profession because we like to help people. We like to help our patients get back to play or whatever they're trying to do. So by improving my patient care and seeing that I'm doing better for my patients, then that is also increasing my job satisfaction. So the next couple of slides here are just going to be examples of how I have implemented patient disease-oriented outcome measures in my clinical practice. So I'm going to share 2 case series that a classmate and I worked on over the past 2 years here as part of our research. The first one here is a lateral ankle sprain study where we were looking at the effects of Mulligan concept distal fibula mobilizations with movement on patients classified with grade 1 lateral ankle sprains. And as you can see here, we implemented these outcome measures at intake and each successive treatment, used that to drive our discharge criteria, and then followed up with them 1 month after treatment to look at some sort of long-term effects of our treatment. The first category of outcome measures we use are looking at the patient's perceived pain and function. So that's through the NPRS, the DPAS, and the PSFS with 3 specific activities that are important to our patient. In this case, they were soccer athletes, so walking, running, and kicking a soccer ball were their important activities. Then we look at some more region-specific outcome measures, such as the FAM for activities of daily living and sports activities, and then the lower extremity functional scale. And then we have some functional measures with the weight-bearing lunge test and the Y-balance test in the anterior reach direction to, again, just have some objective measures of the patient's function. And again, having outcome measures like this through successive treatments is important because they can identify the meaningful clinical changes that we're seeing in our patients to, again, justify that our treatment plan is working and also justify our discharge criteria. The second case series that we worked on was with low back pain patients. We actually tried to have more of a global perspective with low back pain patients, and we performed evaluations based on their diaphragm function. So again, we broke down our outcome measures into different categories. We have our self-perceived pain and function through the NPRS, the PSFS, and the DPAS, looking at that through each successive treatment. And then we also had our diaphragm assessments, where we're looking at the function of the patient's diaphragm to determine whether we felt it was dysfunctional or not. And we used the modified manual assessment of respiratory motion, the high-low test to do this. So then from here, when we have patients with dysfunctional diaphragms that are experiencing low back pain, we use breathing-specific corrective exercises to treat them, as opposed to treating the local region of their back. The last set of outcome measures that we used were disease-oriented with the self-evaluation or breathing questionnaire, as well as the modified OSWES-3 low back pain disability questionnaire, looking at their low back pain objectively through scores that way. So overall, what's next for me? In terms of my clinical practice, now that I'm reaching the end of my DAT, the skills that I've learned in terms of reflecting, evaluating, and refining my clinical practice is something that I hope to continue to do. As we all know, athletic training is an ever-changing profession, so we can't be complacent on what we know now. We need to continue learning with the profession. And in terms of my career, I feel that my goal is to stay in clinical practice. I love working in the collegiate setting, so I want to continue that. In terms of furthering my education, I'm not sure if I want any more formal education, but obviously through continuing education to expand my clinical skills that way is something that I'm very interested in. Potentially be an instructor or professor for an athletic training education program. Teaching manual therapy courses is something that I would be interested in. Obviously, we all know that athletic training is a big mentorship education program where when I was going through school, I had a lot of mentors that taught me a lot of things, and I want to be able to pay that forward to the future athletic trainers by being their mentors as well. And then lastly, just continue with my personal development, again, trying to be the best I can be every day at work so that I can help my patients as much as I possibly can. So in conclusion, overall, I would say I had a great experience with the DAT program. My cheesy quote is, nothing in the world is worth having or worth doing unless it means pain, difficulty, and effort. And I would say that's a great way to just overall describe my DAT experience. There were definitely times that I was like, why did I decide to go back to school? Why am I putting myself through this? I'm working already. Why do I want to have to study and do homework at night when I get home? But ultimately, now that I'm nearing the end of the program, I definitely feel that all that pain and effort and time was definitely worth it. And I feel when I look back at where I came from, what I was like pre-athletic DAT and what I am like now clinically and professionally, I feel it was definitely worth it. And I'm glad I made that decision. So obviously anybody that has any desires to do things like this, I would definitely suggest you check these kind of programs out. So last but not least, I just want to thank mentors and coworkers, both past and present, classmates, friends, and family for their support through this journey. My patients who put up with me trying new interventions and signing forms and taking part in research studies that obviously patients aren't always interested in doing. They just want to get in and get out. But and then last but not least, the U of I faculty, just for the program they put together, for caring about their students, both as people and as professionals. It's definitely made a big difference for all of us. So, does anybody have any questions?
That was
good job.
I feel like I don't want to breathe really shallow, so it wasn't like this little